A workplace is like a centipede. It only works if all the legs are moving in the same direction. Person-centered care is a framework approach to patient care developed by McCormack and McCann, where a unique care path is designed taking into consideration all of the circumstances affecting the patient's admission. It is essential to consider the patient's own individual needs, values, and beliefs, and to actively involve them in all decisions that need to be made throughout their entire admission. This ensures the best outcomes are achieved for the patient. The person-centered care framework focuses on three key areas. Prerequisites of healthcare professionals. These are considered the building blocks focusing on the attributes of staff. The care environment. This focuses on the context in which the care is provided. And person-centered processes, focusing on providing a care in a way that evokes person-centered practices. This framework has been used as a guiding principle for developing standards of care. For example, the Nursing and Midwifery Board of Australia have utilised some of the key factors in their standards for nursing practice. The benefits of using this framework to guide patient care include improved quality and safety of healthcare, reduced care costs, increased patient and provider satisfaction, lower staff anxiety levels, and decreased patient mortality and infection rates. The physical environment, effective staff relationships, appropriate skill mix, shared decision-making systems, power sharing, potential for innovation and risk-taking, and supportive organisational systems are the elements that make up the care environment. We'll be discussing these today.
Physical environment. In person-centered care, the physical environment refers to the design and structure of the healthcare setting. Many hospital settings are designed around clinical efficiency. While these environments are most practical, they often are the least desirable to patients. Healthcare setting where factors such as light, sound, space, and the degree of control a patient has in the environment are more desirable to patients and can have positive impacts on their health. In the year 2006, Joseph stated that natural light can be responsible for improved mood, and in a study by Bookman and Hayes in the year 1998, patients in sunny rooms were discharged earlier than those in dull rooms, demonstrating the potential effect light can have on patient care. The physical environment should attempt to eliminate environmental stresses, including artwork, reducing medical smell, consideration to room acoustics, and as mentioned, consideration of lighting are some physical factors that promote healing and nurturing care to the patient, possibly improving their outcomes.
The relationship between nurses is a key component in achieving holistic person-centered care. Interpersonal relationships between healthcare workers play an integral role in the outcome of care experience for the patient and the family. Positive work environments breed quality work, and therefore fostering positive relationships can improve the healthcare setting. In order to provide person-centered care, collaborative work is essential, as one nurse cannot provide and attend to each patient's holistic needs. There have been several studies conducted showing the impact of quality of care and that patient satisfaction suffers when there are difficulties between staff relationships. Wagner et al. Suggests that there are beneficial outcomes to cross-group friendships. These friendships are shared to encourage team members to be more understanding and empathetic to fellow group members' intentions. There is also sufficient evidence suggesting that effective staff relationships play a massive role in the cohesiveness of a nursing team. In order to provide the optimum level of nursing care to patients, teamwork is required. It is important for each team member to be respectful, kind, and understanding to each other. This cohesiveness translates and can be noticed during interactions with patients. It is imperative that the attitude begins with the leadership team. It is the responsibility of those said to be in leadership to foster and influence an effective and positive care environment by encouraging communication and collaboration within the staff.
Skill-Mix is a unique formula that is developed for each specific workplace to coordinate how many staff members they need on for each shift, according to their patient number and acuity. It takes into consideration each of the staff members' qualifications, for example, AINs, ENs, RNs, CNs, and NUMs. Also, the level of experience is crucial for determining the minimum requirements needed to make the shift run safely. Every hospital can have different scope of practices for each different level of nursing staff. This plays a big role when forming rosters. For example, enrolled nurses at one hospital can have a full scope of practice if they completed added competencies, This allows them to be staffed with another RN and for the ward to be safely covered. However, at other hospitals, they may need to have a second RN as well as an EN though, as the EN can't complete some of the tasks. Skill mix not only involves the nursing staff, but also on a larger scale includes allied health and other hospital staff, all of which are an essential part to allow the ward to run smoothly. A poor skill mix is unsafe for patients and then adds additional stress to leadership staff and the rest of the nurses, which increases sick calls and staff fatigue. Wards must then rely on agency or casual staff to fill in for regular sick calls, often resulting negatively on skill mix, and then adds unnecessary stress to staff, further promoting staff fatigue and burnout. This promotes unsatisfactory culture within the staff, which can have negative impacts on patient care. Another important consideration for leadership staff when determining the ward skill mix is ward budgets. More experienced staff cost more, so a balance between appropriate skill mix and cost must be achieved.
Shared decision-making is an organisational decision and commitment that involves collaborative, all-encompassing measures of engagement between a team. Shared decision-making doesn't only include having the patient involved in their care plan and decision-making, it also involves the need for exceptional teamwork that allows everyone to share ideas comfortably and have discussion when it comes to making decisions. It is crucial that the team has respect for each other, their values and culture, as well as an appreciation for the skill mix and stage each team member is at. Everyone can bring something to the table. The environment needs to be psychologically safe with the absence of hierarchies, bullying and exclusion of team members. With that being said, it is important that each individual knows their own values, strengths and weaknesses and is accepting of others' ideas and opinions. The team needs to be adaptable, flexible and have an ongoing commitment to help staff grow and continue to learn, as well as aid innovation and maximise everyone's potential. There needs to be evaluation tools set in place to evaluate the performance of shared decision-making, learning and shared governance. It is important that all voices are heard and respected, including the patient and their family, to give the patient the best possible care.
Power sharing refers to the strategies that are put in place for team development and enhancing staff relationships. When people come together to work in groups, there is always the unavoidable issue of power and the effect it has on the team. This has a key impact with implementing and maintaining effective staff relationships and needs to be strongly considered when undertaking shared decision making, which is a main component of teamwork where power sharing is used for engaging in person-centred care. Power sharing within teams enhances person-centred care by boosting morale and job satisfaction for nurses through making their input about decisions and their contributions feel valued. By improving morale for nurses, it creates a more stable work environment and helps reduce barriers to communication between colleagues and patients. In regards to teamwork, organisations tend to have ingrained hierarchical relationships. This means that in order for the balance of power, it requires clinicians to go against existing hierarchy-based practices and ingrained institutional practices that can create the basis of domination within teamwork.
The potential for innovation and risk-taking. There is an increasing interest in patient-centred care being innovated across healthcare organisations. However, the process of innovation is very dependent on organisation culture and leadership. By establishing a clear target of patient-centred care and by addressing conditions for innovation, policymakers can improve the implementation process, pace and quality of patient-centred innovation. Conditions for innovation include leadership development along with training, smart regulations and inter-organisational cooperation. SMART Goals is a tool used to help ensure goals are attainable. This acronym stands for specific, measurable, achievable, relevant and time limited. These conditions are used to ensure staff are well supported and have the necessary skills and knowledge. A participation and cooperation between providers and health planners and policymakers is crucial to ensure successful transformation of the healthcare system to implement a person-centred approach to nursing care.
McCormack and McCann refer to supportive organisational systems as those that promote initiative, creativity, freedom and safety of persons. Success in any multi-professional workforce is underpinned by staff who feel a sense of support, safety and respect. Hospital settings are no exception to this rule. In fact, the stakes for a supportive workplace are higher, considering the care of other lives are in the equation. Kerwood proposed that the way a hospital's staff were treated was directly reflected in their level of care towards their patients. This encompasses the need for supportive organisational systems within hospitals to maintain a high level of patient care in terms of the care environment. An exceptional example of real-world supportive organisational networks is seen in magnet hospitals. This title is given to hospitals as the highest level of acknowledgement for nursing excellence and high-quality patient care. To gain magnet status, a hospital must meet extensive criteria across three main areas: administration, professional practices, and professional development. Overall, these hospitals see improvements in both their staff and patient outcomes, with better work conditions, lower staff turnover rates, and better workplace relations. Patients also have shorter lengths of stay, lower mortality rates, and higher reported satisfaction with their level of care. Overall, ensuring that staff are emotionally and physically cared for, as well as allowing them to have professional freedom to be involved in decisions regarding patient care, lead to a significantly better care environment for patients. One possible leadership challenge in terms of the physical environment is the ever-changing technology available in healthcare. While there are many new innovations that can greatly assist in healthcare and the environment that it's delivered in, for example, electronic healthcare records and biometrics, costs are usually the limiting factor in choosing to adopt new technologies. This can be difficult for nursing leaders when they know a new technology could improve patient care, but hospital budgets won't allow it.
Leadership challenges for appropriate skill mix is all about finding the right balance of nurses. As ENs are starting to have a wider scope of practice and are cheaper to employ, wards are increasing their number of EN to RN ratios so that they can employ more of them. However, only certain RNs can officially be a team leader. This enables the ward to run safely with effective leadership. This costs the organisation a lot more money, so we'll usually only put one team leader on per shift.
Potential leadership challenge surrounding effective staff relationships and shared decision-making includes moving past ingrained hierarchical leadership styles of the past. Houston, 2008, stated that there was a paradigm shift in nursing in the 21st century, moving away from industrial-aged hierarchy leaderships towards relationship-aged leaderships. The new relationship-aged leadership focuses primarily on the relationship between the leader and his or her followers, and involves collaboratively working together with a common purpose. In the healthcare environment, this translates to a leader who is collaborative and allows input from all staff and the patients to make decisions regarding patient care. For leaders who have this industrial style of leadership, it can be difficult for them to move away from that.
Autocratic leadership style is a form of leadership which centralises the delegation of power and the process of decision-making to an individual. When this is implemented, this undervalues the input of other team members and removes the capacity for shared decision-making. Autocratic leadership styles impair psychological safety, hindering open communication, creating a negative atmosphere for individuals, reducing their ability for inclusion within the team, which can lead to reduced performance, whilst being detrimental to the implementation of person-centred care within the care environment.
A potential leadership challenge when innovating change is discrepancy of perceptions and expectations among team members. The leader needs to ensure each member clearly understands their role, has resources to perform that role, and lastly, that all expectations and communication is clear and open in all directions.
One of the greatest leadership challenges in nursing is the need for defined leaders at every team level. Ensuring adequate nursing leadership is said to be a foundation for excellent person-centred care. Too often, leadership and management are used interchangeably, when in fact the two groups have different scopes in their relative work environments. Management are often limited in their actions and freedoms due to their position within an organisation. Leaders, on the other hand, have the potential for greater freedom and higher risk. Their goals may be more personal and not necessarily aligned with the organisation. One example of a real-world nurse-led initiative has been the development of the Nurse and Midwife Support Program by the Nursing and Midwifery Board of Australia in 2017. This service is available to nursing staff, employers and educators and provides 24-hour telephone support as well as online resources ranging from tips to staying healthy to advice on what to look out for in staff with health problems. Working in a taxing environment such as healthcare can take its toll on workers and support isn't always immediately available to staff. This confidential service provides additional support to health workers, allowing them to maintain their own health and continue to provide a high level of care to their patients.